Hey, Carolyn.
There we go. Okay.
I hear you.
Hi, hey, Rabbi. He's muted. How's everybody?
Well, it's just me, so you got me. That's about it. So, oh, there's other people.
Now we're
I'm
all
on.
on mute. Hello, Carolyn.
Hey, how are you?
Hello, Carolyn.
Good to see you.
Hey everyone, we will get started in just a moment. Tim Hatch. No, it's coming through the computer. Oh. So we have to mute it. Tim said he could hear me. Okay. I'm gonna be right back. That's fine. I really probably should do it too. Make sure this is.
Good afternoon. Can everybody hear me?
Good afternoon.
Okay.
Good afternoon, Mayor.
Very well. Thank you all for joining us today and taking time out of your schedule. I know everyone has done all of their Christmas shopping and their holiday shopping, and I'm the only one that's left. So I'm going to try to be brief as I still have some tasks to carry out, as evidenced by that U.S. Postal Service box that's over my shoulder. So I'm glad that you all don't enjoy the last minute pressure that I enjoy of Christmas shopping at the last minute. That is just a fancy way of saying I'm a procrastinator. and I know this by now. So doesn't matter what I do, I'm always gonna come down to the last minute. And so here we are. But I want to thank all of you for your work in the community and for taking time out to join this call. I want to thank our policy aide, Phil Insler, for setting this up. It's very important for us to try to talk with you all as often as we can, in particular around issues that are very sensitive to this community. And that's still regarding the COVID-19 pandemic and the novel coronavirus that as of recently has claimed over 256 members of our city. And it's something that obviously we're all still trying to balance. Many of you all are trying to deal with it as faith leaders. And obviously many others are dealing with it in various other capacities, whether it's our schools or whether it's our places of business. And I know that, many people are exhausted and somewhat tired of discussing it, but the fact remains that it's still here and it's an area that we must address so that we can get through this season, if you will. And recently I convened a new task force comprising the medical, health, and community leaders from Montgomery to really help us plan this COVID-19 response. And even though we now have the vaccine coming to the public, it's going to be a while before most residents of Montgomery will have access to it. And so while this is a much needed step for us, it's not something that we can just kind of relax and say, well, it's over now because the vaccine is here. And there are a lot of questions about the vaccine. There's a lot of skepticism. A lot of rumors and misinformation that's out there. And so I wanted to make sure that you all got the opportunity to hear from some of the members of our task force and medical experts that could explain some of this to you so that you can share it not only with your members of your house of worship, but also for other community members, because as I often remind people, there's so many leaders in this community, not just those of us that are elected. And you all serve as pillars in this community and as voices of reason. And so there will be people that will ask you many of the questions that they will ask the mayor and they will ask the governor and the congressman and so forth. So I think it's important that we have an honest, straightforward conversation around this. And I think that in particular, given the disparities and some of the things that have tragically happened in Alabama, specifically referencing the Tuskegee syphilis experiment and those stories and the like that stay with people of this community, it's important for us to try to get as much transparent information to everyone as we can to dispel some of the myths from some of the facts that are out there. And so we're still learning how to respond to this. And we know that as mayors, it's our job to try to convene groups like this and others to share the information that we're getting and to bring along experts who can expound on some of the general topics. And that's why we wanted to come together today. And we wanted to make sure that you had an opportunity to talk directly to members of our COVID-19 task force and other medical experts in this field to address any questions that you might have to try to share. So before I turn it over to our panel, I want to acknowledge Grace Lesser and Cecily Gray and Partners in Health, which is a public health nonprofit which has been providing guidance to the city on the response to COVID and help facilitate this call. We're certainly grateful that our friend Brian Stevenson, who's on the board of Partners in Health, initiated this relationship. And Partners in Health does incredible work throughout the world to make healthcare accessible to those who otherwise might not be able to afford it or have access to it. And so now I want to introduce some of the bright members of the medical community that we have on this call. And each of these experts will speak very briefly, and then we'll open it up for some Q&A. And I want to start by asking Dr. Bram Whisperway, I think if I pronounced that correct, to speak. He's a associate physician in the Division of Global Health Equity at Brigham and Women's Hospital in Boston, Massachusetts, a world-renowned hospital across the board, does fantastic work, and is on all the lists of best places you can go if you have everything from a toothache to things that are more serious than that. So we're grateful to have him playing a role here today. And Dr. Whisperway's research focuses on structural racism in hospital triage and care, and he does teaching across the country on the COVID-19 vaccine. We also have with us Carolyn Byrne, Director of Government Affairs for the Alabama Department of Public Health, who has been deeply engaged in this response and helping us craft our approach to this, not only from the political or elected and administrative side of this, but throughout our medical community. So we want to thank her for being a part of this. And lastly, I want to thank my good friend, Dr. Brian Gary, who's served as a member of my transition team and as a general surgeon and head of robotics and minimally invasive surgery at Jackson Hospital here in Montgomery, and has been on the front lines of fighting COVID-19 right here. And he's also a deacon at the church where he grew up, and that is the Dexter Avenue King Memorial Baptist Church. And so he does take off the white coat every now and then to do the work of the church as well. So we want to thank Brian for being here. And so as they are speaking, we want to let you know that this is an interactive conversation. We will not be on it very long because we know you all have busy schedules, but you can post questions and comments in the chat. So if you look down at the bottom here, you'll see a little icon that has chat in it. And we'll have Phil, who'll be kind of monitoring this for us, to maybe raise some questions so that you don't forget them or you don't feel like you have to wait to the end to bring up an issue. But certainly if you decide to wait to the end, that is fine as well. And Phil will help facilitate this Q&A. So with that said, Dr. Whisperway, I will turn the floor over to you and you can go from here. Thank you.
Fantastic. Thank you, Mayor Reed. And thanks everyone for having me here today. Looking forward, I'm going to just talk for probably about 10, 15 minutes, really about kind of some of the basics about the vaccine, what we know so far. This is obviously information that's really kind of changing and updating almost on a daily basis at this stage. And so I'm just going to go through a few of those before passing it on to other speakers. So, I'm going to start here and just talk a little bit of basics about vaccines and about the coronavirus vaccines in particular. So we have now, the way we do studies on vaccines, they split them into 4 phases. And actually, before you even get to phase 1 in human beings, you test them in animals and in the laboratory. And there's about 100 vaccines for COVID right now that are in that stage. And as you can see here in phases 1, 2, and 3, we have a few dozen, including now 2 that are fully approved for full use in the United States. The Pfizer vaccine, the Moderna vaccine, as I'm sure everyone's heard lots about. Now, there's a lot of things we still don't know about these vaccines, including the ones that are already being given to Americans. For starters, we don't know about children. Pfizer's enrolled above age 12, but are only now currently prescribed for people ages 16 and above. What we do know is that they seem to be very effective in treating people, in preventing symptomatic disease. But what we don't know is how effective they are in preventing asymptomatic disease and spread of COVID. So those are some of the big areas of limitation at this stage. One thing that's been a big concern, and probably some of you may have questions about it, is the fact that these vaccines were developed very, very quickly compared to usual years that it takes to develop a vaccine. There's a couple reasons for that. Number one, already a lot of vaccine efforts had gone into effect for SARS, which had come out, an outbreak in China a number of years ago, and MERS, the Middle East Respiratory Syncytial Virus. And those viruses are also coronaviruses that make a spike protein, all right? And so they developed a lot of the technology on how to target this spike protein, which attaches to human cells and then gets inside the cells. So the vaccine promotes antibodies so that those antibodies attach to that spike protein so that it can't attach to the cells. And a lot of that technology had already kind of been developed because this coronavirus that causes COVID is quite similar to other coronaviruses in that respect. The other important thing is that they used an emergency use authorization to get this vaccine out to people. And I've already been vaccinated as of last week. So to get it started earlier, because usually they track for a number of months. They pour through all the data and they wait to see about side effects. Now, they still did a long period, 2-month period to track side effects before they started giving this to people. And most vaccine side effects happen within the first 6 weeks, even the most serious ones. And so this did reach a certain threshold that the FDA felt was safe to start administering it. So let's talk about the different vaccines you're going to be seeing here in the coming months. The first two I just mentioned are in some ways the most controversial because they utilize a new technology, mRNA, that's never been used before in any vaccine. They also are harder logistically to deal with because they require very cold temperatures. So Moderna has to be frozen. Pfizer has to be ultra frozen at -70 Celsius. And this obviously creates huge logistical challenges for cold chain because once you thaw it, you only have 5 hours to administer all those doses that you just thawed, right? You can keep it in the fridge for a few hours, a few days even, but once you thaw it, and you have to start giving it to people, right? And you get about 5 doses in each vial, sometimes as many as 6 or 7, and so we may get a few extra. Moderna just needs to be frozen, and then we have a couple others on the way, the Johnson & Johnson, which is being tested in 1-dose formulation as well as 2 doses, AstraZeneca, which you may have heard some about, and Sanofi and Novavax as well. Importantly, the technologies, the viral vector technology and the protein recombinant technology have already been utilized before, and so we're much more familiar with how these work for the Johnson & Johnson, AstraZeneca, and Novavax. What is important, I think, to talk about with how effective are these vaccines? So when people talk about 95% effective, what they studied was, do people develop significant symptoms? They did not study whether this vaccine actually stops people from developing minor, like no symptom COVID disease, right? Now, we do have some early data from Moderna to suggest that even after 1 dose of the Moderna, which requires 2 doses, after 1 dose, there was about a 63% reduction in asymptomatic infection. And what we've seen in both Pfizer and Moderna is after about 10 to 14 days, people start becoming less likely to develop COVID compared to people who got placebo. So it seems like even after 1 dose and even after a few days, these vaccines start to take into effect, all of which is very encouraging, but we still have gaps in our knowledge. Now I'm going to talk a little bit about how we're thinking about allocation here. There was a National Academy of Sciences document that was being used to sort of think about how are we equitably going to make sure this vaccine gets to the people who need it most. Now we have an advisory committee on immunization practices, part of the CDC, that split this into 4 categories. Leave it up to a bunch of scientists to claim it's only 2, but as you can see, they split phase 1 into 3, and then we have a phase 2. So it's actually 4. So the first one, as people probably have heard by now, it's healthcare personnel, and then long-term care facility residents, so people living in nursing homes. That's 24 million people. Okay, we should be able to get through that by the end of January, we hope. Then now we're looking at the phase 2, and now we're talking about frontline essential workers. So they've bifurcated essential workers into 2 groups. So frontline, including first responders, teachers, a number of other groups that are considered to be more exposed, as well as persons aged 75 and older. So the way they actually have been thinking through how to prioritize people is a combination of 2 things. One is who's most likely to get really sick and die, right? And age is the biggest predictor of morbidity and mortality from COVID. So those folks got moved to the front of the line. And then also who have we seen in the first 9 months of this spread has been particularly exposed, right? And that includes essential workers. There's been huge inequities, in terms of communities of color being harder hit. And so those are the groups that those two reasonings were how they kind of put people to the front here. The third group, and that's 49 million people. So that's a pretty big group. And then next we go from people 65 to 74 years of age, and then people less than 64 years of age who have comorbid conditions, things like diabetes, et cetera, that put them at high risk, and all the other essential workers. And so that's 129 million people. That's a bunch. So you're talking about over 200 million in each of these first three stages, which is pushing 60% of the total population. And then everyone else kind of goes into phase two. So that's the way that's working on the national level. And our subsequent speaker is going to talk a little bit more about the specifics there. Another way of viewing this is here, which gives you a sense, however, how big these different groups are. Tells you about roughly how many millions of people. So the long-term care facility here in the light blue and the healthcare, the HCP, those are the people in 1A. And then the next lighter blue is the frontline workers, and then the darker blue is the 1C. And then the final group there is in white. And so that gives you a bit of a sense of how the priorities, another type of visualization. The goal here with the vaccine is to develop to get to a point of herd immunity. Now, this is probably going to require about 2/3 of people, or 70% of people, become vaccinated. And the whole idea there is that, some people could still be getting COVID, but that they're unlikely to spread it on to anyone else because they're surrounded in their life by people who, for the most part, have been vaccinated. And that's how you develop herd immunity, and that's how you drive spread of a virus down to about zero. Now, that's going to require enormous effort, and it's going to take a lot of time. I'll talk a little bit about how big of an impact we can expect the vaccine to make in the near future. We do think it's going to save lives, but it isn't going to be the magic bullet that we want it to be for the first half of 2021, which I think is really important to point out, is that we really got to stick to the bread and butter of promoting all of the safe practices that we've been talking about to date. So this is just to drive that point home. Broader mask usage from now until March will save 56,000 lives, and we can get everybody to use masks. The vaccine rollout is only going to save about 25,000 lives in the same period. So again, just to clarify that this isn't going to be the what's going to get us out of COVID in the near future, but ultimately it is a thing that's going to sort of keep the virus at bay. Now, one other final point I'll make, and this has already started to happen with Pfizer vaccine, is that the estimates of how many vaccines we're going to be getting and by when have been over optimistic at every stage to date. It wasn't that long ago that they were talking about 100 million doses by January. Now it's probably about 30 million people could be vaccinated by January. And so just to make up the point that there will continue to be hitches in the distribution chain, in the manufacturing chain, and all sorts of other issues that will probably make this kind of roll out a little bit slower than what people are predicting. And so that should be expected, and why we're going to be dealing with this virus a bit longer, than some of the more optimistic predictions we've seen recently. Finally, along this step, and I'm really glad Mayor Reed brought up some of the equity concerns around COVID. And, this is really what we think about it at Partners in Health, right? With the preferential option for the poor, among other sort of key components of our work, is how do we make sure this vaccine distribution is done equitably? And, part of that is an extra challenge, because we're not just talking about like, this is an unequivocal good that everybody's going to want, right? Where there's a lot of things we don't know about this vaccine, and there are legitimate concerns that people have. One, because this is a type of vaccine that's never been given before, and two, because for some communities, and you brought up Tuskegee and others, there is decades and centuries of history of medical malpractice on top of all the structural racism that's occurred in society, and people are understandably feel that public health institutions, medical institutions, are not trustworthy, in this sense. And, also these large pharmaceutical companies that are the largest money makers in the world, right, are not necessarily very trustworthy, right? And so we have to understand that people are going to have very real hesitations about taking this vaccine. And it's not because they're necessarily anti-vax or they're necessarily prone to myths. It's because they have very real concerns in this history. And so what we need to do is make sure we are providing very honest, very clear information about what we know and what we don't know, and giving people the option, particularly our most marginalized communities, the option to get vaccinated if they want to, without putting people in a position where they feel like they have no choice but to do this and their concerns. And so we've been thinking about this framework, basically a 4-part framework of all the areas where we can think about equity and work with our public health partners on maximizing equity. So that includes in the framing, as I talked about, and you'll hear more about soon in terms of how it's going to affect your community in Montgomery. Social mobilization, so having the community take as much control over this as possible, right? Thinking about that trustworthiness piece. Who does the community trust when it comes to messaging about health, about vaccines, and having the community also be, be able to control where that's being given and when. Thinking about delivery, right? People are working, essential workers have, maybe working long hours, working 2 jobs. How can they get vaccinated outside of those windows? Really making sure this works for them. So thinking about how to do equity on that standpoint, and also, making sure we can get this vaccine into places where people are not well connected to the health system. I got vaccinated at a hospital, right? Some people aren't going to the hospital, they aren't seeing their doctor. We got to bring the vaccine to them. And finally, on the follow-up piece, making sure we're getting people the second dose, which we know will protect them, fully after that first dose, and tracking adverse effects if people have them, and making sure those are documented. One final point I'll make just about the adverse effects, which people are probably worried about. I got this vaccine. I have a history of anaphylaxis in the past, so severe allergy, not to a medication, but to food. I got the vaccine. I had some arm soreness myself. But what's been described so far commonly are things like fever, chills, headache, the usual vaccination side effects that people get from flu vaccine and others. There have been 6 documented cases of anaphylaxis out of about 300,000 doses given. So really pretty low risk so far, and that's being monitored very closely, but severe reactions have really been limited to that. So just to say we do, the data is still emerging, but so far there haven't been any real scares or disasters, which I'm sure, your constituents and, are going to be very, very, concerned about. So it's good to sort of be prepared with some of that information. So I'll go ahead and stop there, and we'll move along.
Great. And Carolyn, if you're still with us, the floor is yours.
Hello, everybody. Thank you so much, Mayor Reed, for allowing public health to participate in this gathering of clergy, and we thank everybody for being on. I wanted to talk a little bit about Alabama and where we are on the vaccine distribution, and then I wanted to ask for everyone's help. We, as you heard in the prior presentation, we did not get the amount of vaccine that we had anticipated when we started getting vaccine last week. So last Monday and Tuesday was our first vaccine distribution of the Pfizer vaccine, which has to be handled very carefully. And that vaccine, we were expecting 112,000 doses in the state, and we received 40,950 doses. Our next Pfizer distribution, which is coming into the state this week, we thought we were getting 48,000 doses and just received 26,000 doses. So what I want the community to understand in Montgomery is that the vaccine is coming sort of in drips. We are getting Moderna vaccine, which is an easier vaccine to handle because it does not require the ultra cold storage temperatures. It does require freezers. and it is still fragile to a certain extent. We're expecting 84,350 doses in the state over the next 3 days. So that is sort of where we stand during Christmas on vaccine distribution. Now, there is a vaccine allocation plan that every state has, and I think we look like many other states in that we looked at infrastructure and the healthcare infrastructure first. If we don't have doctors and nurses, if we don't have people that clean the rooms, if we don't have the people that do the laundry vaccinated, then we can't serve our citizens in hospitals or in clinics. So shortages of doctors and nurses and support personnel in hospitals and in clinics is very real when we have a high spread and high risk exposure environment. So in Alabama, we are targeting healthcare workers, nursing homes, and nursing home residents first. In this state, we have approximately 320,000 healthcare workers and nursing home residents. So I just told you we received 40,950 doses. We're getting another 26,000 doses, and then we have another 84,000. And if anybody does math faster than I can do math, we have approximately 120,000 doses that are coming into the state. These are all first doses. What they're doing in the CDC is they are putting aside the second dose. So if they send us 40,950 of Pfizer doses, they put aside 40,950 so that our second doses will be in inventory. So I just want to reassure you all of that. So we have about another 180 to 200,000 healthcare workers to immunize before we go to our 1B population, which we just found out on Sunday when the ACIP met, that will be our 75-year-old and above, which I know we've gotten calls from a lot of 65-year-old people who thought they were in that second grouping, but this is what was recommended. CDC just put out their recommendations, and I have been in so many meetings, I have not even had a chance to look at them yet. So here is what's going to happen. As we get past this first group of healthcare workers so that we can maintain our infrastructure to take care of our Montgomery citizens, then we're going to move into 75 and older and some critical infrastructure workers, which are still to be defined. Because we just got CDC's recommendations today, and Dr. Harris, our state health officer, will address that. Here are some of the things we're concerned about in Montgomery. Number one, in Montgomery, we're critical right now. We have about 1 in 12 residents that have COVID, which is pretty high. We're going into the Christmas holiday and New Year's Eve. And so we are extremely concerned about our population and just the spread and the exposure that these holidays, offer our citizens, and people are fatigued. We have analyzed by census tract where our older populations are, where our chronically ill populations are. So actually in Montgomery, with the help of and I have one of our epidemiologists with me right now, with the help of some very talented epidemiologists, we can tell you all where in Montgomery the 1B population, this is the next population that is targeted for vaccine allocation, actually is by census tract. And we are happy to share that information with everyone. In fact, in about 2 weeks, we're going to put on a program for faith-based organizations statewide, where we're going to go over the maps and we're going to go over vaccine hesitancy issues, and we're going to have Dr. Harris and Dr. McIntyre join us to talk a little bit about that. So I invite everybody to that, and I will share that information with Mayor Reed and Phil. So what we'd love to have your help in is, number one, please make sure everybody is safe during the holidays. Our spread and our risk is very high in Montgomery. We certainly don't want to see more deaths, and we certainly don't want to see more people hospitalized. My boss, Dr. Scott Harris, said we had reached 5,000 cases in Alabama in one day. And when you look at that, when you look at 5,000 and then 4,000 was another day this week that the number of cases in Alabama, when you look at those numbers, approximately 10% of those daily numbers will be hospitalized. And so when we're looking at those trends, and you can imagine 5,000, well, that would be 500 people. 4,000 would be another 400 people. You can see that we may be at a tipping point. Of course, I will let Dr. Gary address that next. So here's what we'd love to do. We have developed a survey, and the survey focuses on vaccine hesitancy in communities. And we are asking that our partners in Montgomery, our faith-based organizations, our community partners in Montgomery, if they talk with their flock or they talk with their neighbors, that it would be very helpful for us to distribute this survey to you all and ask for your help in just gathering some information for us on vaccine hesitancy. Alabama is a big state. The way we message in Montgomery is not going to be the same as we message in Madison County, which is not going to be the same that we message in Bibb County. So I think we have a unique opportunity while we wait for the vaccine to come into the state and work through the healthcare providers. As I said, we have about another 200,000 statewide. We have an opportunity now to get you all to help us understand if we have pockets in Montgomery County with concerns about vaccines. Some of you may have concerns about the vaccine, and we would love for you to share that with us. The other thing that I will say is that we want to manage expectations. As the good doctor said earlier, we're hoping we get a lot of vaccines in the state over the next 4 weeks. Everybody's essential. Everybody's critically important to get a vaccine too. We want to make sure it's done equitably. We are setting up pods. We have 91 sites now that we've set up across the state, and they're going to be in pods where they're responsible for going out into communities. We know in Montgomery, we have the FQHCs, we have urgent care centers, we have rural health clinics, we have the Montgomery County Health Department, and Tim Hatch has joined me on this call. He's the Assistant District Administrator for Montgomery County. We will be having clinics also. So there will be a lot of access points. I saw somebody ask about homebound people. Right now, as far as healthcare workers are concerned, we are reaching out to clinical and non-clinical people who are doing in-home care for our residents. So I do want to reassure you that we are very aware of people that are homebound, and we'll be targeting them. Right now, we're targeting their caregivers. So I did want to answer that question, Phil. I hope you don't mind, since it was up on the screen. So any questions for me? So you may have to read them to me.
I think that was the only one. The rest are both.
Yeah, that was the only one for now, but once we open it up, there may be some more. Before we do that, Dr. Gary, do you want to just kind of tie it all together and share any thoughts? And then again, after that, we'll open it up for questions, comments, concerns after that.
Good afternoon, everyone. First of all, thank you to everyone that's here today. Thank you, Dr. Whisperway and Carolyn Byrne, for that information. And really appreciate you all taking the time so we can have this very important conversation about what's happening in our community. I'm Brian Gary. I'm originally from Montgomery and I'm a graduate of Tuskegee University. So Dr. Whisperway actually mentioned Tuskegee and the distrust that has been in Alabama for many years, rightfully so. So being from Montgomery, being from Tuskegee, I'll be the first to say it's unimaginable for me to see and hear people think that this is not real. So what I want to do today is bring you kind of an account of what I see on the front lines at Jackson Hospital. There's a stark contrast between some of our citizens here in Montgomery thinking that, hey, I had COVID, it wasn't a bad deal. Well, as we know, the virulence of this disease affects us all differently. And patients that are older and have more comorbidities are at higher risk of having a more virulent outcome. So it pains me when I hear people in the community think that this is not real. It is real. We're going through a second wave now. And thanks to our Mayor Reed early on being proactive, we were able to control those numbers, but we still saw a critical number in our hospitals. Now at Jackson, our ICU usage, our ER usage is back to almost what it was, if not higher than even earlier during the first wave. And I say that our ICU stays at or near max capacity. Just spoke with one of my ER physicians just yesterday, and we have patients in the ER waiting to get ICU beds. Now, of course, this is not all COVID related, but I don't think we think about it like that. We kind of put it in boxes, but there's a significant, serious downstream effect from COVID. I'm a surgeon. What I've seen is patients that have acute and chronic disease wait significantly longer to get help because they're afraid to come into the hospital. So patients that will come in with appendicitis and we'll get it out in one day have stayed at home for 2 and 3 weeks. I've had cancer patients that didn't want to come in to have cancer surgery because they were afraid of being in the hospital. So we have an opportunity once again to be proactive and to serve our community. We have an obligation to do this for our family, for our neighbors, for healthcare workers. And I'll tell you, we just got an email from our hospital yesterday saying that we were expecting the vaccine today. You don't know how many physicians cheered and was saying, I'll be there, let us know. Now, we just found out in reference to what Carolyn said, it didn't show up today. But I say that to say if healthcare workers are willing to be one of the first to get vaccinated, it's not just because they don't believe, we truly are here to help one another. So I know there's a lot of distrust. I know there's a lot of rumors going around about efficacy, side effects. We all took a Hippocratic oath as physicians. Healthcare workers in general go into healthcare because they want to help and they want to make a difference in patients' lives. We have an opportunity now to serve those purposes. So we have to let our community know that, look, if we're doing it, it's okay. We have a situation that's real right now that we have to address, and we don't have the pleasure of the time to wait and react. In medicine, you have preventative medicine, you have treatment medicine. This is a form of us being able to stop something, prevent future worse outcomes. And that's coming directly from me, from my colleagues, from the people that are in healthcare. We want to get control of this and get past this so that we continue to be the Americans that we are and humans worldwide. Now, I'm talking to clergy. As mentioned before, I'm a deacon at Dexter Avenue King Memorial Baptist Church. So I know your role as leadership, and I know your flock comes to you for advice and listens to you. And all of us here mainly know, we know that God doesn't make mistakes. So from that standpoint, we have to trust in our healthcare field, in our scientists, and those that have done the work to make a difference in our lives. And we have to go forth and do what we can to make this better and place our trust in God. I'm waiting on the vaccine to come. I'll be in line to get mine. And I hope that everyone else does as well, because that's the only way we can continue to get past this and put this pandemic behind us. Thank you.
Great. Well, thank you all. And there are a couple questions in the chat that I'll throw out. And so our panelists, feel free to answer it if that's in your realm of expertise. And then after that, if anyone has any other questions or comments, go ahead and unmute yourself and ask them. or you can put them in the chat. We had two questions from Rabbi Kramer. The first one was asking just to speak a little bit about the mutation that's been in the headlines the last couple of days out of the UK. We got a response in the chat, but Bram, if you can speak to that. And then a second question as well is that from Rabbi Kramer that there are 2 approved vaccines. And Carolyn, maybe this is a question for you, just asking what the timeline is and quantity estimates for those.
Yeah, thanks for the mutation question. These kind of viruses are generally going to undergo some mutations that are going to have kind of a range of effects. And usually if they become more easily spread, they usually become a little bit less virulent, so like less damaging. And so it seems like this one might be more easily spread, but very likely that could also mean that it's a little bit less deadly, but we'll see. It's almost certain that the vaccine will still work, because if the virus mutates so much that spike protein, which is the target of the vaccine, if that's no longer able to be a target of the vaccine, that also means it's no longer able to be a target for human cells. And so then it will have actually just become so mutated that it's no longer able to impact people. So almost certainly any of the mutations we see while it's still spreading in people means that this vaccine will still be effective. It could be, though, concerning if this is spreading more quickly, and it would just mean that we have to take even more serious precautions at this stage. I'll just add in real quick, the only other vaccine besides the 2 that are going to be available, very shortly in Alabama, the Pfizer Moderna, is the AstraZeneca. Its data has been a little bit complicated, and it got a lot of criticism, but it's the only other vaccine to date that's released some data. So it will probably be available in the next 2 to 3 months. It seems to be a little bit less effective than the other 2, but it does have some data suggesting it's effective at preventing asymptomatic disease. And it uses a technology that may be able to create longer lasting immunity than the Pfizer and Moderna, but those are all questions still to be determined. So that one may be coming in the next few months. The others, they haven't released data yet, and they have to wait until they enroll a certain number of people, and a certain number of people in their study develop COVID. And so they can't predict exactly when that will happen. But given when they started their trials, we expect them to be releasing that data in the coming months. Now, that they could be negative studies. The phase 2 suggests that they're effective, but there was one big blow up already in an Australian vaccine where it turned out to not be really effective, and they had to abandon it. They had $1 billion contract with the Australian government. So we haven't, for the most part, all the predictions have not relied on those subsequent vaccines. We hope there will be more coming that are effective, but we have to kind of plan as if, these are the only 2 we've got for now. And, that really might take months and months and months, towards the end of 2021, depending on how the manufacturing processes work and the distribution processes work.
And I'll just add on the Alabama side that we do not get quantities of vaccine until the last minute. So there is no way to predict. I mean, we knew that, we were told initially 112,000 doses of Pfizer, and they cut us by 2/3. And so really it's week to week right now for us to know this. We're hoping that after the first of the year, we might have a little bit better estimates of how the vaccine is coming into the state. But at this point in time, we cannot address that. It's been a very fluid situation. I think everybody will agree with that who's worked on this.
Any other questions, thoughts, comments?
Yeah, I'd be curious to know what you all are hearing from your constituents, your people, in terms of what the concerns are, and if there's any information that we have that would be valuable.
I was speaking with a group of young people who have a foundation here in the city, and they were doing some volunteer work here. And I asked them, about 6 young African-American men, are you planning on taking the vaccine when it becomes available? I know you won't be on the high priority list because of your age and general good health. And I was stunned to hear all 6 of them say, no way, I'm not going to do it. And so when I hear Dr. Gary's comments about the reality of this, it makes it really important, I think, for us as servant leaders, faith leaders, to speak directly to that kind of fear, which might seem unreasonable to folks who are on the front line, like you, Dr. Gary, and you, Dr. Bram, but it literally stunned me that that kind of resistance was there. And most of the, I'm sure they've heard of the Tuskegee experiments. I'm sure the cultural and systemic things that we've talked about have influenced their views, but the adamancy with which they said absolutely not was stunning. And so it is going to be critical that we address it as respectfully, but I think as bluntly and forcefully as we can as well.
Yeah, I want to second that. I've got some members in my congregation who have been directly impacted by the systemic racism built into the healthcare system. You know, they've been personally affected by the less pain management, delayed treatment, all of these things that you know, quite frankly, most white folk don't even know is real. So on the one hand, it's been a great opportunity for the congregation to have some conversation around this, but it is real, and it's not Tuskegee era. It's current day, and my folks are looking for the public health institutions to demonstrate actions and progress in that area. Frankly, I suspect there's a handful that will not be prepared to take the vaccine. Most recognize that their fears are more intense than is rational, and they will move themselves into being able to take it. But I suspect we've got some that won't for that reason.
I think another area that needs to be addressed, yes, we're talking about the fears, but also the access. When we deliberately target specific times of day in which we know that those who work certain jobs would not be available to take the vaccine, then you're really not trying to get them the help that they need. So if you target hours like 9 a.m. in the morning to 11 a.m. in the morning, when the majority of them are going to be at work, then you're really not trying to make this available to bring about the much needed help. So I think access is going to have to be a priority.
And I realize this, you probably don't have a response prepared, but I'll bet you're thinking about some things. How can we, as leaders of faith communities, support this effort? You know, aside from, I heard you, Ms. Byrne, talk about the survey, and certainly happy to help with that if we can, but what else? Are there ways besides just fostering conversation and encouraging people to move toward vaccination? Are there practical ways that we can be of service on the ground?
I think that part of this is, you know, certainly we're in a very unusual pandemic. And so how do we, you know, I'm very concerned to hear about the young people that said they definitely would not take it. And we know we're going to come up against that. So I think what we're trying to do is look at why will those 6 young men tell you that they're not going to take it? What is the core reason? And I think you all are the people on the ground that have the trust in your communities. And if you can find out some of the barriers, help us in finding out some of the barriers. I mean, we discussed some of them, but I think that, you know, I've heard people, and I don't really think it matters where you live. A lot of people tell me because the vaccine was rushed, they want to see who takes it. And then if somebody doesn't drop dead, they're willing to take it. So, and I mean, I say that tongue in cheek, but that's what I've heard. I've also heard that people tell me there's putting chips. So when they give you the immunization, they're putting a chip to track you. And I said, well, if anybody has a cell phone, they're already doing that. So, I mean, that's not the thing that's gonna, you know, we need, but I do think that there are a lot of different reasons that people are either from an access standpoint, like we brought up, and I think that was a very wonderful point, that we have to make sure we have different hours and weekends and things that people can go to. So thank you for that. But I think it depends, the messages that I'm getting, and I work statewide, it is very different what stops people in one community from another. All right, let me give you, so you all can help be the feet on the ground, the eyes and ears that we're not hearing from. We need your help in asking those 6 people, why are you so adamant that you won't take it? What is the reason for that? So I also think as we start to target your communities and share information with you all, I think having a dialogue, you know, around this is that you can sort of help us get to the people who want the vaccine also. So we're looking at this from 2 different sides. We've got to work on the side where people are hesitant, but we also want to target those who really do want it. And I think that's where you can help us. So we know that we're going to be the end of January, beginning of February before we start on 1B. If nothing, you know, if we have a miracle and we get 1 million doses tomorrow, then I'll change that. But as of now, so I think that if you all can help us think through this, we're going to be able to map where our highest risk patients, where our highest risk citizens are. So we can tell you by census tract. And then I would like to reach out to the faith community and say, do you serve the census tract? Are you able to reach people in this community? Can you tell us who wants it? So that we get, because it's coming in drips. So I'd love to get the vaccine to the people who really want it, and then have them help us. We also want to have messengers. I mean, we're happy to do different PSAs and work with community leaders who have the trust of the community. So I'll give you an example. I was with a senator yesterday, and one of his constituents that he represents, she went to see her grandmother, her aunt, her sister, and another grandmother, and she spread the disease among the whole family, and they lost 4 people in her family because of that. So if we have people that have passionately seen how this disease spreads and has impacted their family, and they can help speak to others in their community. I lost an aunt and uncle to this disease, so I understand the ramifications. I think that's how you can help us. Identify those people in those communities who really believe that this is a danger. I mean, Dr. Geary told you about a lot of people. He's working in the hospital seeing these horrible things. One of the problems is we're a visual society. If people had polio, they would see people in iron lungs. They would see things that they don't see today. I think when polio hit Montgomery, my husband said that they were all lined up to get the polio vaccine, the drop on the sugar cube, because they were seeing people in the community and they were visually seeing people that were suffering. I don't think we have that with COVID. I think that people don't see it. And I think that's one of the problems. So anyway, that's a long answer. So we do need y'all's help in being the eyes and ears.
And just to add to what Carolyn was saying, doing what you're doing today, equipping yourself with this information so that you can have these conversations with your constituents, so you can disprove myths, is a way to connect. And also to be ready, all of you all are leaders. So a lot of people will follow just based upon what they see you do. I didn't go into any real particulars, but it's a number of colleagues, surgeons, medicine doctors, hospitalists here in Montgomery that have been affected by COVID-19. And so the more we can tell those stories, the more it becomes more believable, and we're willing to not just wait and see. And it's so unfortunate to hear about the 6 young men in our community. And I know that that is real, but I'll tell you, in Montgomery, that's not the only group of people that don't want to take the vaccine. There's a whole nother demographic for different reasons, whether it be political or what have you, that don't want to take the vaccination. And so a lot of times, you may not be able to change those minds, but if we continue to do what we think is best with the right interests and leading by example, eventually people will come around. You have early adopters, late adopters. We're not going to satisfy everybody and cure this with one dose. But the more people willing to step up, be leaders, do what they feel is right in their conscience, the better off we'll be long term. So I commend you. Thank you for taking this meeting. Continue to educate yourself and continue to shout it from your pulpits and have these conversations with anybody that'll listen, because that's the only way we'll get by.
I'll just jump in for a moment. Good afternoon, and echo something Carolyn said, which is that in conjunction with this city, we're working on shaping messaging for a communications campaign around the vaccine that is transparent and that is oriented to specific community concerns in Montgomery. So the first step in shaping that messaging is really having these types of conversations and one-on-one conversations with community leaders like yourselves. So we do have some of those set up even this week. And if you're interested in having some of those discussions so that we can best understand what your members are feeling, thinking, concerned about, where hesitancy is rooted, we would love to have those discussions. And I think building on that in the coming months, it's going to be most important to show trustworthiness in order to build trust. So to Reverend Lover's point around access and hours of vaccination and having community access points and using vaccination as an on-ramp to provide additional care for folks. Those are all pieces that the city and certainly ADPH is thinking about as well.
Great, and I know we have a few other questions in the chat. We will definitely follow up with those afterwards, as well as the slides and the recording of this. But do want to be conscious of everyone's time. So Mayor Reed, do you want to close it out? Mayor Reed, you're still muted over there. If you can unmute yourself.
All right, sorry about that. I want to thank you for facilitating this, and I certainly want to thank Dr. Wispaway, Dr. Gary, and Carolyn for their help in this, and certainly all the faith leaders who've taken part in it. This is just the first step. It's not the last step or last conversation we want to have. Hopefully we can grow this group as well to bring in more leaders as we have these conversations, because we're going to be dealing with this for some time. So if you have any questions that you didn't think of today, please feel free to reach out to us, and we'll make sure that we follow up with you and get you the proper information you need to share with your all of your members, but also other members of the community as well. We just have to try to spread the word as much as we can, and that's why we wanted to have this conversation with you. So please share this as openly and widely as you can. Again, this was recorded, so we hope to share this on our social media sites. And so those that could not attend, or those who obviously have a lot going on today or just weren't aware, can go back and look at some of this information. And we want to try to publicize as much of this as we can. And I think the more people hear about this from people like yourselves, the better they'll be able to deal with some of the misinformation that may be out there, or maybe even just some of the justifiable concerns. Maybe I shouldn't call it misinformation, but some justifiable concerns that do exist. So thank you all again, and certainly for all of you who celebrate, we want to wish all of you a Merry Christmas. We want to wish everyone happy holidays and enjoy this time with family and friends and loved ones. And I guess a early Happy New Year. Let's just get to 2021 because it has to be better than 2020, I believe. So thank you so much. And we really appreciate all of your leadership and your involvement. And we'll leave it right there. Take care and stay safe.
Thank you.